Hi everyone, welcome back again to Smarter Nursing YouTube channel, and today we'll be continuing our introduction to pharmacology just like we have begun before. But today we wanted to discuss a few pharmacological terms so that while we round up our introduction to pharmacology and we go into other pharmacology concepts or pharmacological concepts, we'll be able to comprehend what exactly we are saying. So the first term we'll be considering today is a drug. Now, that's quite funny because, we all feel like we know what a drug is, and we exactly know, or we've seen drugs, we've gotten tablets, we've gotten all of these things. But today, I'd like to tell you that what you have been calling drug, tablets, capsules, are not exactly what they are. So while we dig into pharmacology, we'll be able to understand this concept. So firstly, a drug. Now, when I talk about drug, the first thing that comes to your mind is the tablet you get at the pharmaceutical shop or a pharmacy that contains different tablets. But in reality, that is not exactly what a drug is, because that which you get from the pharmacist is called a drug product. Now, why is this a drug product? Because now, a drug product is the finished form. It is the normal one you go to a pharmacy and get, or you get prescribed to when you visit the hospital. But when we talk about the drug, we're talking about the exact chemical compounds, the active ingredients that make up the drug product. So indirectly, what I'm trying to say is that if I get a tablet of paracetamol, that is not a drug. That is a drug product. Now, what else is the drug? A drug combines with some vehicle substances to form a drug product. Now, this is what I'm trying to say. Pharmacologically, we can say that the chemical compound paracetamol, let us consider the chemical compound in a paracetamol. Now, if this chemical compound that I just wrote here, we add it with some vehicle substances. Now, what do I mean by vehicle substances? These drugs are not yet exactly in the form where they are easily ingested, or the form where they are to be, like either a capsule or a tablet or whatsoever. So vehicle substances could be anything starting from additives or fillers or flavorings, colorants. Think of anything, preservatives. So when this main compound is added to a vehicle substance, we are going to get a drug product. So indirectly, a drug product becomes basically the finished form of a drug. Meanwhile, the drug itself is the active ingredient itself found in the drug product that helps, when it's taken into a body, effects a change, either to treat, to diagnose, to prevent, or whatsoever, or to vaccinate. So this is different from what a drug product is. So the next thing I want us to check out is the receptor. What is a receptor? I'd like us to note something. And what I'd like us to note is that when you get a drug product, and ingest a drug product, it does not exactly just work because it has passed through your esophagus to your stomach, and then you just like, okay, it's working. The first way, or the first role that a drug should undergo before it begins to bring about systemic effect is absorption. And what's absorption? Absorption is basically getting into the bloodstream. It means that when that drug has successfully gotten into the bloodstream, and then while in the bloodstream, it is already absorbed. From the bloodstream, it is supposed to be distributed to a lot of tissues. And why it is distributed to those tissues, that is when a drug binds with receptor at the particular site. Now, let's use this as an example. Let's consider a patient that is going for a surgery, and this patient has to have some anesthesia given or administered to them. And let's say the particular anesthesia administered is the IV Profolo. Now, I needed to know something. This drug is supposed to create an effect when it gets to the brain, right? Well, when I take the drug from my mouth orally, does it automatically get to my brain? No. So the only way that drug that was taken per mouth or per oral will be able to work or have an effect in my brain is when it gets to the bloodstream, because it's at the bloodstream that distribution happens to every part of the body, and then the affected part of the body begins to effect a change. So now that we already know this, what is the receptor? The receptor is what exactly is going to be or to receive this active ingredient at the sites where they are needed. So using this anesthesia IV propofol as an example, when this drug is taken, it has to cross the blood-brain barrier while doing the systemic circulation. And then when it gets there, there's some receptor. Just think of the word receivers. They are ready to receive this drug to make a change. And there are different stages when it comes to receptor or drug receptor interactions, and we're going to actually talk about that very soon. Okay, the next thing I want us to consider is the biophase. It is important to know that the bloodstream itself is not the biophase. First thing, let's look at what a biophase means. A biophase is the effect site. I like to call it the effect site, and what that actually means is the main site where this change that we are looking for happens, right? Okay, so let's explain this in simple terms. I would say that it's the immediate environment around the receptor. The bloodstream is not the biophase. The biophase is the exact area surrounding these receptors of which this binding and receiving and effect exactly happens. What am I trying to say? When a drug gets into the bloodstream, like we discussed, and then this drug is carried away with the blood and circulated around the body, or when this drug has gotten into systemic circulation, it would get to the point where the effect is needed. Let's go back to anesthesia, which we talked about. It's supposed to get to the point where this IV propofol would then begin to work or to get to the cross the blood-brain barrier and produce this change. Now, the exact area where that receptor is, the environment around that place, is the biophase. Now, that the blood has gotten into the bloodstream does not exactly mean that it has reached the biophase, because even if we want to use this anesthesia, which we'll be using as an example to describe, we'll be able to recall the fact that when a patient is given anesthesia, immediately it is administered, which anesthesia is mostly given intravascularly, which is directly into the vein. Immediately it is administered, you would see or you would notice that it's already in the bloodstream, but then the patient does not lose consciousness immediately, because we already know that the anesthesia helps to lose consciousness, so for patients that want to or are undergoing surgery. So in this case, the anesthesia is already in the blood, but the anesthesia is not yet in the biophase. Now, such kind of thing are what we refer to as the lag time. So the lag time can happen. There are different types of lag time. There's the pharmacokinetic lag time and the pharmacodynamic lag time. Well, in reality, this is what we're describing now. We're going to talk about that later. But the lag time is drug has gotten into the blood, but it has not yet reached the area where it is needed, the area where it is to bind with the receptors. So you can see that you check a person's blood, you see that the drug concentration level is high, but then the effect is not yet showing, and that's because it is yet to reach the area, the particular receptor surrounding the tissues. I want us to talk about drug receptor interaction, but before we talk about drug receptor interaction, I want to give you an idea of how exactly drug crosses through the plasma membranes. So right now, we'll be talking about the passage of drug through plasma membranes. And as much as this is something we'll cover a lot when we get to pharmacokinetics, but I really want us to have a general idea of what exactly I mean when I say that drug passes through the plasma membrane. Now, for every drug to exactly get an effect, it has to get into the blood, because without the drug, remember, not the drug product, the drug having to show the signs or give this effect in the body, it needs to get into the bloodstream. I want us to just have a quick idea of what it means for a drug to get into the bloodstream. So I started by drawing this. Now, what does this frame represent? This frame or this image or this sketch is just to show us an example of what a cell membrane looks like. And now, around this cell membrane, it has different layers and the layers are named according to how much absorbing they are. Now, let's imagine that we take a drug ingestion, and it passes from the mouth through the esophagus and down to the stomach and then to the small intestines. Along the line, these drugs have to get absorbed or else they won't get into the bloodstream. And absorption is practically a drug getting into the bloodstream. Now, let's imagine that this is a membrane of either the small intestine or the stomach. Now, this part of the membrane, this is the outer part, right? And we can describe this as the part that is exactly facing the tissues, the surface of the tissue. We can describe this part as the part that is directly facing the cytoplasmic fluid. Well, that is not our main subject of concern currently. What we want to discuss is these drugs has to pass through this part, and this part is what we call the hydrophobic. Now, we already know what hydro means, and hydro sort of signifies water, and phobia sort of signifies hatred. So this part, which is the main part where the drug molecules are supposed to pass through, is the hydrophobic area, meaning that it is against water, or we can also call it lipophilic, which is liking fat. So hydrophobic or Now, what does this mean? It means that for a drug to exactly cross through membranes, it has to sort of be in a lipid soluble form, because it's only a lipid soluble form composition that's going to be able to pass through these fat loving areas, right? I want us to get that concept. Now, this outer part, which is the water soluble forms, and it is the hydrophilic. Now, we've already discussed our main subject of concern. How do we now get drugs to be able to pass through these areas? There is an equation that help us to understand what sort of drugs will pass through some sort of areas and what sort of drugs will not pass through some sort of areas. And the name of that equation is the Henderson-Hasselbalch equation. And that is what we're going to use to explain this concept of drug passing through plasma membranes. Now, what does this equation simply signify? This equation simply say that weak organic acid, which is drugs that are in form of weak organic acid, would be able to cross a membrane that is acidic in nature. And a drug that is in a weak organic base form will be able to cross a membrane that is basic. Right now, let's think about some membranes that are sick. We already know about the stomach, and while we were in school, we learned that the stomach contains gastric juice. Now, what is gastric? We already know that while the stomach contains gastric juice, it's very acidic. So we can say that the stomach is acidic in nature. And knowing fully well that the small intestines are very basic in nature. Now, we're using the Henderson-Hasselbalch equation that says that weak acid would be able to absorb better in an acidic environment. So we can use this to say that weak organic acid will absorb better in the stomach, and while weak organic base we absorb better in the intestines. Now, if you are able to learn only this, it's quite very okay. But I would want us to know why. Why is this so? Why would weak organic acid absorb more in the stomach and weak organic base absorb more in the small intestine? So we'll start by discussing how weak acid absorb primarily across the stomach. This equation will help us understand this. This represents the acid, and this represents our hydrogen ions. And if we remember what an acid means from chemistry, remember that an acid is anything that dissolves or dissociates to give up hydrogen ion as the only positive ion. I think I remember that from chemistry. So now let's imagine that this equation helps us to understand why weak organic acid should dissolve across the stomach. We have already been able to establish the fact that we need drugs to be in their lipid-soluble form to be able to pass through membranes. Why? Because membranes are lipophilic. They are fat-loving. And so therefore, it only takes a fat-soluble substance to be able to pass through membranes. And we need this drug to get into membranes, to be able to get into the bloodstream, to be able to enter systemic circulation, and to be able to be distributed around the body, attached to receptors in the biophase and whatever. Now, how do we get this possible? Now, this is this drug in its lipid soluble form, unionized and its lipid soluble form. Let's think of a drug. Let's think of a drug that is acidic in nature. Aspirin. So we're going to be using aspirin. Another name for aspirin is the acetylsalicylic acid. Now let's work with aspirin. We need aspirin in its lipid soluble form to be able to cross past membranes. If this would represent our acetylsalicylic acid, which is its lipid soluble form, it dissociates to give up the hydrogen ion and the acetylsalicylate. Why is aspirin dissociated? And we already know that while it is dissociated, it lost hydrogen ions. Why? If this weak organic acid loses hydrogen ions, it will become less acidic. So it's no longer acetylsalicylic acid. Now, this acid we have here is our lipid-soluble unionized acetylsalicylic acid, which is basically aspirin. But when it loses some hydrogen ions, it becomes the acetylsalicylate. And this is now water-soluble. Remember, we want our drug to be in a lipid-soluble form, to be able to cross past membranes. So now, when the acetylsalicylic acid loses some hydrogen ions, it becomes the acetylsalicylate. And in this form, it is no longer lipid soluble, but it is water soluble. Now, what does this affect us? What that means is that if an acid or an acidic or an organic acid in form of a drug like our aspirin drug loses hydrogen ions, it would become acetylsalicylate and water soluble, and this water soluble form cannot pass through membranes. Now, we do not want this. We want a drug that is able to pass through membranes. Because we want a drug that will be able to pass through membranes, we want a drug to be in the lipid soluble form without losing hydrogen ions. Now, if an aspirin is taken into the stomach, it crosses the stomach first. And we already discussed that the stomach has a lot of acidity. What that means is that if an aspirin is found in the stomach, it, instead of losing hydrogen ions, it finds more hydrogen ions, because hydrogen ions already represent acidity, and hydrogen ions is basically the definition of an acid, and an acid will give off hydrogen ions as the only positive ion. So what that means is that right here in the stomach, there are a lot of hydrogen ions. So what that means is that an aspirin would rather, instead of losing hydrogen ions, we combine with hydrogen ions, more hydrogen ions, to give off what? Higher dosages of the acetylsalicylic acid, not the acetylsalicylate, which is water soluble. So you see that an aspirin is likely to dissolve more in the stomach. So let's rephrase this. We already learned that we need a drug to be in a lipid soluble form. Acetylsalicylic acid, which is the aspirin, is in a lipid soluble form, but the acetylsalicylate has lost hydrogen ions. But if I am to take an aspirin and it crosses through my stomach first, a large percentage of the aspirin will be digested across the stomach. Why? Because of the high percentage of hydrogen ions. Knowing full well that this is an equilibrium equation, what that means is that it is reversible. So if there's a high amount of hydrogen ions, they would move in the backward direction to form more of the acetylsalicylic acid, and this is the lipid soluble form, and this would dissolve better in the stomach. Now, how about bases? Now let's see what difference does base do. Weak organic bases dissolve more in the intestines. Now, we're going to use the Henderson-Hasselbalch equation. So I like to use this to explain why weak organic bases will dissolve more in the intestine. These represent base, these represent hydrogen ions, and these represent the base in addition to the hydrogen ions. Now, let's use a common example of a base. We already know from organic chemistry that an amide or an amino could serve up as a base. So let's use the general formula for amides or amino to describe this. So we're going to have something like this. Now, the drug in this form is the lipid soluble and unionized. While the drug in this form is water soluble and ionized. Now let's make this make sense. When you take in a basic drug, an example of a basic drug, codeine is a basic drug. So if you take in a codeine, this is a drug in its lipid soluble state. Now, when this drug passes through the stomach, what happens? When codeine, which we represented with our amino general formula, passes through the stomach, it combines with hydrogen ions and immediately it becomes the water-soluble and ionized form. Now, our Henderson-Hasselbalch equation already tells us that weak organic bases dissolve more in the intestine, and that is what I am trying to explain. Now, if I should take this codeine molecule or this codeine chemical or this codeine drug and it passes across my stomach, what happens is that it combines with hydrogen ion molecules, and when it combines with hydrogen ion molecules, based on equilibrium, it would give up the water soluble and ionized form. Now, we do not want our drug in a water soluble form because when it's water soluble, it cannot diffuse through a membrane, and we want this drug to cross through a membrane and to give off or to enter the bloodstream, enter systemic circulation, and go to wherever we want it to be. So what that means is that if I am to take a codeine molecule, which is a weak organic base drug, and when it passes across my stomach, it would not dissolve in my stomach because it immediately converts to the water soluble form. And when it is a water soluble form, it cannot pass through anything. It cannot pass through the membrane, the epithelial linings of the blood vessels that are around my stomach. So what happens? What happens is that when it now goes into the intestine, and we know that our intestine is a basic environment. Okay, I already wrote that. It's a basic environment. So if it is in a basic environment, it loses hydrogen ions, meaning that we would rather lose hydrogen ions. And when we lose hydrogen ions, based on this is a reversible reaction, it will convert and become the lipid soluble form. So indirectly, if I should take this codeine and when it gets into my intestine, it goes back to the lipid soluble form because at the intestine there are no hydrogen ions, so it loses them, and when it loses them, it goes to this form. So when it is in this form, it will easily absorb across the intestine. So we cannot see that it makes sense that weak organic acid diffuse across the stomach while weak organic base diffuse across the intestine. So since we already know this, I want us to talk about drug receptor interactions. Drug receptor interaction is just the interactions that happen when a drug finally meets its receiver. Now, we already described that when the drug gets to the particular place it's needed, there is a receiver, which we call the receptor, that is ready to take this active ingredient, bind, lock, and produce effect. Now, what do I mean by all of these things? There are steps that drugs go when they meet up with their receptors, and the first step is the binding step. So just consider it sort of like a lock and key mechanism, right? So just think of it that I have a receptor in this form that is basically in this shape, and I'm coming forth with a drug in this form. Now, what do you naturally expect? You expect that this drug will just bind in with the receptor, and when it bind in with the receptor, it becomes this. And you see, with it already properly fitted, it either works to cause an effect or it works to stop an effect. So when drugs finally meet their receptor, this is when the effects that we expect from drugs generally occur. Now, the first step, which is what I just explained as the binding step. Now, what do I mean by the activation? Not every drug that binds to a receptor exactly activates it. I want you to think of something like this. If I should have a padlock and its lock, now this is a padlock and its lock, and I want this padlock to be able to lock in and be able to produce an effect. What I would expect is it to activate. Now, some drugs can either activate after binding, can either activate to produce a conformational change, or they can activate to not produce anything. I want you to think of something like this. Now, let's imagine that I get the head of this key and bind it in this lock. Then I use the key for the padlock to put it into the padlock and close the door, and the door is able to close. Now, my main aim when I got the key and the padlock was to close this padlock so I can lock my door and go home. So when I walk it through this way, I would be able to see that, well, this worked, and when I connected it, my door was closed at the end of the day. Now, we call this kind of mechanism the agonist. Now, what's an agonist? An agonist is primarily when a drug meets its receptor and it brings forth a conformational change after binding. Because like I said, not every drug that binds to its receptor brings forth a conformational change. So if the drug binds to the receptor and is able to bring forth a conformational change, it is an agonist. Now, there are some drugs that after binding to the receptor, it does not bring any change. I want you to think of something like this. I finally get my padlock and my key, but after I bind it in, it can't lock. I'm trying to run off. I'm running late. I'm running off to church. I'm running anywhere, but I can't just possibly lock my door, because even after it's able to fit in properly to the key, it cannot lock the door. So an antagonist is basically an activation mechanism that after the drug is able to bind fully to its receptor, it does not produce a conformational change. It does not produce the change that we expect. So there are two different types of the risk activation. The activation step, it could either be the agonist or the antagonist. Then finally, the response. There is no drug interaction that you have to cut out the response, because the response is basically after the conformational change, what effect, what change do I see, general change do I finally see in this patient that was prescribed this drug. So I want us to now go into the dose size of a drug. Now, I like to say that as a nursing student, I mistook a lot the difference between a dose size and a dose, which is because pharmacists and doctors sometimes use it interchangeably, and sometimes they say dose, sometimes they say dose size. It just depends on who's talking. And I asked myself, is there really a difference between dose and a dose size? Well, I want you to know something. The difference between a dose and a dose size is just this word, quantified. Now, why do I say this? Because I might ask you to get paracetamol, which is almost always in a 500 mg tablet forms. The dose is 500. It becomes a dose size when it is quantified. And by quantified, I mean it now has units. So if I should write the 500 without the mg, it is a dose. But from the period I add the mg, it becomes a dose size, because we're like 500 watts, 500 milligram, compared to what? Compared to gram, compared to microgram, compared to decagram, compared to anything. Now we now have some form of comparison that we can compare this drug with. So a dose size is the quantified amount, and it always has units. And I wrote here that it's different from dose. So it always comes with a unit that you can use to differentiate it or to compare it with something else. So now we're going to talk about priming dose. I wrote here that a priming dose is also known as jumpstart dose. Well, as a nursing student, I had my pharmacology lecturer call it the loading dose. Almost the same thing, just different names, but to describe the same thing. Now, what is a loading dose? A loading dose is basically the amount of drug that is needed to be able to stir up the systemic drug concentration to a particular amount in order to produce the desired effect. Now let's bring all this grammar into something very simple. I will use a simple analogy to describe this. Let's imagine that we have a cup of water, and this cup of water is in 500 ml. Now, using my analogy, this cup represents the body of a human and the drug, the blood concentration of a human. Now, let's imagine that for a drug to be able to have effects in the body system, it has to at least have a systemic concentration, which is that the amount of drug in the blood is needed to be 500 ml before it produces an effect. Now, for a drug that is needed to be 500 ml before it produces an effect, when you want to administer such drugs, will you give a drug that is 100 ml? No, because if I should give a drug that is 100 ml, I will not exactly get the effect that I'm finding. I will not give a drug that is 300 ml. Imagine that the first pass mechanism is not considered in this particular situation. We would need to give a drug that is 500 ml to be able to get this body system to start the work immediately. Now, I like to call this the jump start dose, meaning I need to be able to get the blood concentration, the drug concentration in the blood to be 500 ml very fast. Now, how do we do this? What I do, I will just have to take a jug of water that is 1000 ml and pour off water of 500 ml, and it will stop exactly at this line, and that is my first dose. Now this amount of drug that was poured into this cup, which represents our body, and it is exactly 500 ml, is the loading dose, the first dose, the priming dose, the first dose we want to use to raise up the blood concentration, to jumpstart the drug blood concentration to a particular level where we can exactly begin to feel the systemic effects and all of those things, is the large initial dose, which is the priming dose, the first dose. Now, this large initial dose is a large initial dose of a drug that is given to achieve desired therapeutic concentration in blood. So we need the drug concentration in blood to be up to 500 ml before we can feel any effect. What happens when I've already gotten the drug to 500 ml? This is my body, remember? And we already have the drug in 500 ml. Well, different things happen. You can lose water molecule through evaporation. I'm still using this analogy to describe. We can use some water molecule through evaporation. We can lose it through spilling. The water can spill off. You see, the water has spilled off. And different ways we can lose this. Meanwhile, in my body system, we lose the drug through excretion, through urination, sweating. The drugs actually practically diffuse through sweating, or we lose it through urination, through anything, through talking, through whatsoever. Drug diffuses from your body. What that means is that the drug concentration that we needed in the blood, which was 500 ml, would no longer be 500 ml. So what then do? We give a maintenance dose. Now, what's a maintenance dose? After we've been able to get the large initial dose, a maintenance dose is the keep it going dose. We want to keep this concentration to always be at 500 ml. Even after I've lost some drug through urination and whatsoever that we have, I want to still be able to keep it to 500 ml. So what do I do? So the maintenance dose, let's say after we've lost some drug through urination, which in this case of my analogy, I lost some of my water through evaporation, through water spillage or whatsoever, then my drug concentration is now 300 ml, or let's say 350 ml, whatever. I would only need a little quantity more of the drug to be able to top it up to take it to 500 ml. So what do I do in this case? I take maintenance doses. So what are maintenance doses? They are not large. They are the keep it going dose that you give to maintain the drug level. We are no longer jump starting. We are maintaining what we already have existent. That's what we're trying to maintain. So now we're going to talk about the dosage form of a drug. Now, what's a dosage form? It's the finished form, like the form in which the drug product is finalized. Now, let's follow this form. We already discussed that a drug product is the finalized form or the finished form of a medication that is consumable, that is in its right form, constituency, and everything for the patient to be administered to, and when taken, it is safe for the patient to use. Now, this drug product can come in different forms. It can be in form of a tablet, in form of a capsule. Now, these forms, which shape this constituency that they finally take, that these drug products finally take, is called the dosage form of the drug. It can also be found in a syrup. It can also be in the form of a liquid or in the form of an inhaler. All right, so now we're going to talk about liberation or drug release. What do we mean by when we say a drug is liberated? If I get a capsule of a drug and I want to finally ingest this capsule of the drug, I don't need the outer coating. Like, in reality, the main drug product minus the vehicle substances is the active ingredient of the drug, and that is what my body needs. That's what my body needs to be able to take forward that conformational change that would give that effect that you see in the patient. Now, this active drug has to be separated from a dosage form. So the liberation is the process by which a drug that has been taken in separates from whatsoever form it is put in. If it's a capsule, it's separate from the capsule so that the main ingredient, which is the active ingredient of the drug, will be used. Meanwhile, whatsoever form it's separate from, it's not harmful to the body. What it means is that whatsoever vehicle substances is used in creating a drug product should be something that creates no harm to the patient at the end of the day. Because what we'll need, the body needs the active ingredients, and the vehicle substances at the end should be either harmless or of no effect to the patient. So now we're going to talk about extravascular drug administration. What do we mean when we say a drug is administered extravascularly? There are different drugs you take. Some drugs are taken orally, per-orally, but whatsoever drug that you take that does not directly go to the bloodstream. Remember that we say absorption is when the drug finally goes to the bloodstream. What that means is that every drug at the end of the day will get to the bloodstream, but not every drug will get into the bloodstream directly when taken. Some will avoid the bloodstream and have to go through what we call the first pass effect, of which we're going to be talking about later. But for currently, when we say a drug is administered extravascularly, I don't just mean a topical application or just a drug that is applied on the skin. What it means is that a drug that follows any other route or aside getting directly into the bloodstream. It means whatsoever route of drug administration that I can use to take a drug in that would not directly go to my bloodstream first. That's an extravascular drug administration. Now, obviously, as an example, we have topical, we have oral, we have per-oral. Now, you might want to ask, what's the difference between oral and per-oral? Per-oral simply means a drug that is swallowed. It means if I get a capsule, if I get a tablet, and I get water and swallow it, the drug was taken per-orally. But then what then is oral? Oral is basically any form of drug medication that is taken from the mouth. It could be any form. It could be under the tongue, which is sublingual. There are some drugs that produce that would dissolve fast under the tongue. So you just put it under your tongue and it dissolves, and you don't have to swallow. You don't have to do any of those things. There are some drugs that are lingual. There are some drugs that you put by your cheek. All these drugs are all oral drugs, including per-oral. They're all oral. But per-oral is definite. It means exactly swallowing, a drug that is swallowed. So these are kind of different form of drug medication. Now we have the IM, which is intramuscularly. And we know that at the end of the day, this drug will get to the bloodstream, isn't it? Even the drug taken per-orally will eventually get to the bloodstream. But we don't just want that drug to get directly to the bloodstream. We want the drug to go through the first pass effect because of the concentration of the drug or whatsoever. So that's why you found out that some drugs that are taken directly into the bloodstream have some higher concentration or higher dosage than a drug that will go through the first pass effect and lose most of its basic active ingredients. Now we have the subcutaneous, which I'll represent with SC. They don't get into the bloodstream directly. We also have the rectal medication. So rectal drugs are drugs that pass directly into the anus, and from there it's absorbed. From there it gets to the bloodstream. From there to the systemic circulation. From there it is distributed all around the body. Now, what about a drug that is intravascular? This time around, we are trying to get the drug directly into the bloodstream. So we are not confused. We want the drug this time around to get directly into the blood. So these drugs are usually given for fast effect or quick effects, because we already know that the beginning of effect is when the drug gets into the blood. That's how it will be easily transmitted or transported around the body tissues where it is needed. So these kind of drugs are given for fast effect. For example, for an asthma patient or a patient with bronchoconstriction or whatsoever effect needs fast relief, you give drugs that will get directly into the bloodstream. Examples of routes of drug administration that goes directly into the bloodstream: we have the IV medication, goes directly into the bloodstream, which is simply intravenous, and that is directly injecting the needle into the veins, and what's giving it either can be done through the IV push bolus, which is the direct, or the IV drip. So apart from the intravenous, we have the intracardial. This is when the drug is given in into the chambers of the heart. We have the intraatrial, into the atrial chambers. We have the atrium and our ventricle. So these drugs are given into this place. So now we're going to talk about bioavailability. What do we mean to say when a drug has a bioavailability of whatsoever percentage? Now, it's important for us to note that bioavailability is always described in percentage. What exactly is bioavailability? Bioavailability is the percentage of the drug taken that reaches systemic circulation in active form. Now, let us imagine that I take in this drug. Now, this is my esophagus. From my esophagus to my stomach. From my stomach to my balls. Now, whatsoever drug is taken would first of all get into the stomach. Now, from the stomach, as some absorption happens there, remember we discussed that some drugs, weak organic acid, dissolve more in the stomach. But I'm really to know that the main site of absorption is usually the small intestine. It's just why we mentioned that is just to tell you the environment where some drugs are more likely to absorb. So if I have some of drugs absorb in my stomach and they get into the bloodstream, the capillary rods pass through the capillary epithelial lining and get into my bloodstream, they will be transported through the portal vein to the liver. Now, every of these things go to the liver. The liver helps to detoxify, to break down large molecules and whatsoever. Now, from the liver through the hepatic artery would move to the heart. Now, when this heart has pumped or coming from the inferior vena cava of the heart to the superior vena cava, then it's pumped to go into systemic circulation. Now, at the end of all of these movements, you would see that we would have some loss of the drug in the liver. During the drug passes through the liver, after it has been absorbed and passes through the liver, you would find that we have lost a large percentage of this drug. Now, this is what some people refer to as, or this is what is generally referred to as, first pass mechanism. So what is first pass mechanism? It is just simply the processes that drug undergo before finally reaching the desired site of action, in which the drug loses some of its percentage of active ingredients on the way. Now, what do we now mean by bioavailability? We mean what percentage of drug is finally available in active form. I remember that systemic circulation only begins after the blood has been passed to the heart and then to the body. Now, what percentage of drug would we finally find in the body after it has passed through the heart? Because we were likely to lose a lot of drug during this first pass effect. So the percentage that is finally available is what we call the bioavailability of the drug. It means that if I take a paracetamol of 500 mg, at the end of the day, what might eventually get to the systemic circulation is 200. Now, this bioavailability and first pass effect usually happen to drugs that are taken extravascularly. What that means is that for a drug that is taken directly into the bloodstream, there is no need for first pass effect. All right, so now we're going to go to the next phase. We're going to talk about the local effect of drug. What is a local effect? Local effect is an effect obtained when a drug is administered at the site of desired action. I want you to think of when you have some skin itch and when you have pruritus or whatsoever, pruritus, rashes, and you go to visit the dermatologist and a topical cream is given to you to apply at the surface. Why are you applying it at the surface? Because this is where the problem is. The problem is at the surface. Now, in this kind of case, we are looking for a local effect because the drug is administered at the site where we need the desired action. So I'm having itch on my arms or I'm having itch all over my body and I apply them all over my body. I'm expecting a local effect because that is the site of action and that is exactly where I am applying this medication or taking this medication. Now, in the case of systemic effects, we discussed something like the last time where we said a drug that is taken from the mouth, I need the effect of that drug in my brain. For example, codeine. Aside codeine, anesthesia like the IV propofol that we spoke about, it needs to cross the blood-brain barrier. Now, why didn't we just take a medication and inject it directly to see if we can get it to the brain? Because this time around, we are seeking for a systemic effect. So what happens is that when the drug is taken and is absorbed directly into the bloodstream, it eventually finds its way to the site of effect. And as long as the blood trans that is moving, that is circulating around the body, it will get to the point where this effect needs to be done and it will bring about this effect. Now, this is a systemic effect because we did not apply or administer that drug exactly where we needed that change. We administered it the way we would administer any normal drug, and the drug finds its way to where the effect or where the change is needed and affects it by binding of the active ingredient to the receptor. What is drug accumulation? I wrote down here that is the increase of drug concentration in blood upon multiple dosing until a steady state is reached. When I think of accumulation, most of the time I think of drugs with long half-life. Now, we have two kinds of drugs. We have drugs with long half-life and drugs with short half-life. Now, what is the difference? What is even half-life? The half-life of a drug is the amount of time taken for half of the amount of drug to be excreted out of the body. Now, for drugs with longer half-life, first of all, they take long before excretion. There are some drugs that basically take 30 hours. There are drugs like that. Now, what it means is that that drug will constantly be in the body system. Remember the example we gave of how the body excretes, it urinates, it sweats, the blood molecules, they are leaving your body. But in this kind of case, it takes longer to leave. They have a longer half-life. Now, how does this concern this? We have to note that drugs with longer half-life, most of the times, drugs with longer half-life need a lot of quantity to even get to the initial stage of effect. Meaning that drugs with longer half-life mostly always require a priming dose. Why? Because drugs with shorter half-life might not need a priming dose. For example, paracetamol. If I should get paracetamol or Tylenol, you don't exactly need a priming dose because it has a short half-life. Drugs with short half-life are likely to reach their target immediately without needing to, first of all, jumpstart the dose or to get to the dose, then continue with maintenance doses. But drugs with long half-life, like digoxin, you would need a priming dose to, first of all, start it before you can continue with the maintenance doses. Doesn't that tell us something? It tells us that drugs with longer half-life takes long before it reaches the concentration that is needed for the body to create a change. And that's where accumulation comes in. This is the increase of drug concentration in blood upon multiple dosing until a steady state, until we get to the state where the body be like, okay, this looks like we can work with this to effect this change. Now, accumulation is when the drug is continuously administered upon multiple dosing until we get to the point where the body can work with what we have available. What is a lag time? Lag time is basically delay. But there's something I want us to note. There are two different types of lag time found in a drug. Now, what are these two different types of lag time? Remember that initially when we spoke about biophase, I mentioned something about that the drug is in the systemic circulation does not exactly mean that it is in the state where it's needed, that it is in the active site where it needs to bind with the receptor, of which we define the biophase as. Now, that distance between when a drug is given and a drug is found in the bloodstream versus the time it will take before it gets to the active site, that is the pharmacodynamic lag. And I mentioned that I gave an example of anesthesia where I say the drug will be found in the bloodstream, but the patient is yet to lose consciousness until after a while. That time delay before it finally gets to the receptor is the pharmacodynamic lag time. So you can see that lag time is basically delay. Now, if I say this is pharmacodynamic lag time, what then is pharmacokinetic lag time? That is the amount of time taken from the period the drug is administered before it gets to the bloodstream. What does that mean? It means that if I should ingest a drug per orally, the time frame between the time I took the drug by 3 p.m. But by 4 p.m., the drug is not yet in my blood, and let's say the drug arrives in my blood 4:05 p.m. My blood is checked and some particles of the active ingredients of the chemical compound that I took is found there. Now, the timing between 3 p.m. to 4:05 p.m., between the time the drug was administered versus the time the drug finally got to the bloodstream, is the pharmacokinetic lag time. What then is a sustained release? A sustained release is when drug is made in a special dosage form that releases the drug slowly over a long period of time, other than at once. What that means is that we don't want to make use of priming dose or loading dose or whatsoever. We just want this drug to constantly remain in the bloodstream. So what that means, mostly is in the form of a patch. You see something like a chemical patch. Now, what does this patch do? This patch will be attached to whatsoever site it is needed, and the drug is sort of programmed to continuously move at a constant rate over a long period. Instead of just giving this drug as a one start, jump starting the drug, it is administered slowly on its own without having to come for many maintenance doses or to give multiple doses. It is releasing itself. It's a sustained release, a release that continues even after a long period of time. So we've come to the end of pharmacological definition of terms. Thank you so much for joining. If you have any question, drop it in the comment section. If you enjoy this lecture, please help to drop a comment. If there's any part you want me to talk about in the next video other than what I already have in mind, please drop in the comment section. The next video will be discussing the routes of drug administration individually with its practical examples. We want to see how exactly should a student nurse or a nurse or a medical personnel administer these drugs. We want to see the pros, the cons, whatsoever. Why should this particular mode be chosen over this mode as regards this particular medication? Please like, subscribe, share this video, comment on this video, share to your fellow nursing students, share to anyone you think that will find this video beneficial. From our next lecture, we'll be answering a lot of NCLEX questions. For now, we left the NCLEX questions until we get to the route of drug administration, and we'll be answering questions at the end of every video, of which at the end of the day would provide the answers and help you check out the answers that you already had in place. If you're looking forward to write the NCLEX exam, the council exam, whatsoever nursing exam you have in place, this is the right channel for you. Please stay tuned and subscribe for more videos.